My name is Jan Stria and I'm a physician working as a senior consultant for surgery in Salvatella Company, an outpatient clinic specialized on management of non-healing wounds. When I've met Mrs. Pavlina for the first time, she went through a rough patch of her life. She was 38 years old single woman living in a flat with 6 years old handicapped son, totally dependent on her for help. Pavlina was suffering from a venous leg ulcer with case history more than 3 years. She complained of pain, opened exuding wound, reek, and considerable edema of lower limbs. She was treated by dermatologist with antibiotics and steroid ointments and long stretch compression bandages without any improvement of her health condition. Unlike other common patients with venous leg ulcer, she was prepared to do anything to improve the healing and finally close the wound. Her motivation was to be able to keep the infant child without any limitation and to allow her to play a full-time mother role. I guess it was also the reason why our treatment and educational efforts were so effective. We persuaded her that for the best result we have to change the treatment strategy and focus not only on the topical treatment but also concentrate on the lifestyle issues, restriction or reduction of the lymphedema, and stabilization of the skin and soft tissues surrounding the ulcer. And Pavlina decided to improve and adapt her bandaging technique so we could start to teach her how to apply short stretch compression bandages and train her in self-management. I think that our system can be individualized, but in many healthcare facilities the problem could be the time. Patients with chronic wound need to be educated repeatedly, so it's a big communication issue, not only in communication between physician or healthcare givers and patients, but also between relatives and suffering patient. So I think that the reason why some patients are not able to talk about their medical or healthcare problems is that they are not able to name it. The second part of it is that a lot of them are ashamed. They don't want to admit that they have some serious problems. They think that it will be okay, it's only a temporary problem, and they don't have to spend a lot of time talking and discussing such a problem. In outpatient setting, there is a limited time for communication and patient education, for finding out patient expectations and meeting current wound patient and clinician needs. Overestimation of the topical treatment and effects of dressings by the patients and their non-concordance seems to be the biggest barriers we meet in our everyday work with venous leg ulcer patients. Patients' vision used to be unrealistic and the awareness of the treatment is often very poor. So the Czech health insurance companies and Czech healthcare system prefers so-called centered care. But talking about venous leg ulcer, there is a problem because we have no net for venous leg ulcers. Maybe that the situations can be better if we build up really solid net of outpatient clinics or specialized clinics for hospitalized patients focused on treatment of such a venous leg ulcer patients. This story is about finding the best way to communicate with the patient. Also, it can be an example that maybe patients could be more active when they are trying to find specialists which can help them. Pavlina was active, she wanted to change it because she was not satisfied with previous treatment. So she was looking for another specialist, and we were able to help her. Only when we know what problems, what signs are under the bandage, under the dressing, under the skin, we can target them and treat them.